welcome everyone. You are now at the AOT Clinicians Web Chat. And so this is not going to be a webinar or a talk or a lesson of any kind. We want to create community and we want to create shared knowledge. So I would appreciate it if you're able to use your webcam so that we can see who we're talking with. Love it. Thank you. We're going to go ahead and start with introductions. And I will just say, I just finished doing a webinar like 20 minutes ago. So I'm a little, woo. But anyway, my name is Amy Lukes. I am the director of the AOT implementation team here at Treatment Advocacy Center. I am a clinician by training, and I'm accompanied by Betsy Johnson.
Hello, everybody. Betsy here. Nice to see you all. And that was a phenomenal webinar, Amy. Congratulations. You did a really nice job. For those of you who weren't able to participate, it was done in conjunction with Dr. Amador, and he covered his LEAP training highlights, and then we were able to follow it up with some general information about AOT. So I think we had, it was hard to tell as a participant how many people, but I know we had over 1,000 registered, but it's going to be available for a few short days. So if you're interested, we could send you the link to that. But Amy did a great job. So congratulations, Amy.
Thank you.
I would have seconded that. I attended the workshop too, Amy and Betsy. It was just first rate.
Glad to hear it.
Tell you how much we appreciate, I appreciate, and the NSSC appreciates your making that resource available to so many people all over the international audience.
Yeah, we had actually 750 people participating. Right. So
including somebody from Egypt, right?
I didn't look, but they were registered, that's for sure. Brooke, you want to tell us a little bit about yourself?
Hey, everybody. My name is Brooke Gentry. I'm the AOC Implementation Coordinator as part of the implementation team alongside Amy and Betsy. And I mainly manage our resources. So I'm guessing you all found out about this clinicians chat through the email because you're AOT Learning Network members. If it was forwarded to you and you are not an AOT Learning Network member, I would really encourage you to join. We have free educational events like these stakeholder-specific web chats, and we also host webinars and share kind of a slew of other information on AOT. So just in case anyone on here is not a Learning Network member yet, I'll go ahead and drop the sign-up link in the chat. But great to be here and see all of you.
All right, so let's go around the room. Tara, good to see you.
Good to see you too. I'm Tara Sevier. I am the project director for the AOT program in Austin, Texas with Integral Care.
Thank you. Sheridan.
Hi, you can't see me right now. I'm a little indisposed, but I am here. I am a proud member of NAMI as of last year and have been, I don't know, I took probably 12 classes last year so that I would be able to become an advocate for NAMI, which is extremely important to me. They're my people, so that's why I'm here.
All right, excellent. Cassie.
Hi, my name's Cassie Taveras. I work for River Valley Behavioral Health in the Western Kentucky region. We're the Community Mental Health Center. I'm out of Owensboro, Kentucky, and I'm our AOT programs forensic liaison.
That's awesome. Matthew. Oh, you're on mute.
Good afternoon. I'm Matt Johnson, Slidell Behavioral Health Clinic. Our AOT court is 22nd Judicial Court, St. Tammany Parish, Louisiana. and we govern Slidell, Louisiana, and Covington, Louisiana. We had about 20 clients. So just we're new, and just trying to find out what you guys do to be successful.
Excellent. Well, thank you for joining us.
You're welcome.
Kyle.
Hi, I'm Kyle Dennehy. I'm a AOT coordinator in Thurston and Mason County in Washington State. I got forwarded this email for this meeting, so I didn't know why I was coming into, but I did just register for the Learning Network. So I'm just here to see how things are going and see, apparently build community. So.
Yeah, welcome Washington. We're really excited about what's going on there now. Misty.
Hi, I'm Misty Roberts. I am AOT Project Director in Weatherford, Texas, just outside of Fort Worth. Well, was that all I was supposed to say? Sorry, I was trying to deal with the client too.
So, so you're from the Pecan Valley, is that right? Or no?
I'm sorry, what?
Are you from Pecan Valley?
Yes.
Excellent, excellent. Anne Marie.
I'm also from Pecan Valley. I'm the case manager for one of our counties.
Oh, that's great. That's great. Texas represents, man. Edmund.
I'm Dr. Edmund Creekmore. I'm a licensed clinical psychologist. I have been very, very much involved in trying to implement innovative approaches, including what we call mandatory outpatient treatment in Virginia. I'm thankful for Lisa Daly and tax support in finally getting a more effective MOT option in Virginia.
We can't wait to have it actually implemented. Matt.
It is implemented. It has been implemented. It's just not, it's not widely used because judges haven't really learned about it or are still having some issues understanding the intricacies of the code. But we're working on it. And I think the Learning Network may be one option if the judges would like to have maybe TAC work with some of the people that are running these in Northern Virginia. I think they're using it and in the Tidewater area.
Work with them. Yeah, Matt Mooring.
Hi, I'm just hopped on the call. My name is Matt Mooring, and I am the hospital director of Central State Hospital in Louisville, Kentucky. And AOT has been going on for several years here, but we're toward the end of a grant program that has really allowed the program to flourish and is doing quite well. Amy, is there something else I should say by way of introduction?
No, that's great.
Okay.
And just to let you all know, we have almost all, with the exception of Washington, AOT grantees. So between Kentucky and Texas and St. Tammany Parish, that's pretty exciting. So Betsy asked the question earlier, how many of you participated in the webinar that occurred just before this? If you don't have your camera on, just you raise your hand or something. So glad to see that. The one point I always try to make when talking about AOT to any audience is that it's not, I mean, the court order is important. It gets your foot in the door. But the most important thing is engagement and how you get the person who you're working with to see that treatment is in their best interest, that they'll want to participate in treatment. Their life is better. And So I'm curious on what strategies you all use towards that end.
We do a couple of different things. So with my team, we really focus on engagement, and really have, at the beginning, when we start working with someone, our prescriber and our nurse talk about meds, and the rest of the team just really focuses on rapport building, figuring out activities that interest the person, and really starting to build that relationship first before those conversations start to be about treatment. And my team is really good at that. And they've been able to build some relationships with folks that we didn't think would ever let us in their homes. We also have a really dedicated judge, Judge Dan Prashner, who works with us. He read Dr. Amador's book and utilizes LEAP in his interactions with our clients during status conferences, which has really been, I think, a game changer for our program and for him.
Oh, that is so good to hear. What about other folks? And if you don't have an AOT program running right now, like Kyle, what strategies have you used in your past, or what do you intend to intend for your provider to use as well? So feel free to answer from your perspective, whatever your role is.
So I would say, so again, so Central State Hospital is a state owned and operated hospital, and everybody that we have is here involuntarily. And so I think there's I would respond to the question at a couple of different levels. So at the hospital, as we begin we're meeting people where they are at a very low point in their life. And so as they begin to improve, can engage with them and say, look, this is hard. We know it's hard, and we want to be here if you need us, but we don't want you to need us. And so, this is an option that may, in many cases, these people have been here a couple of times. This is a program that may really kind of help you move forward, and then sort of explain how that is and things like that, and talk about the success stories. But it's a different place, because we're not trying to engage somebody that's in the community. We're trying to get them to learn some and hear how these kinds of services might help them. Because there are some people who leave and say, I'm glad I'm leaving. I don't need you. I want to go do my own thing. But by and large, when people are here, they're like, I don't want to feel this way. I want to be, I want to be more well than I am. And so it's a good time to approach them with an idea for a tool and support. And then as someone leaves the hospital on AOT, there are 2 CMHCs that Central State works with and serves those catchment areas. The biggest one is here around the Louisville area and the surrounding counties. And, that CMHC has the larger AOT participant population. And that team is great at going to the community and trying to they've been engaged with them while they were in the hospital. And then when they're transitioning to outpatient, of going by and trying to really fully implement the desired treatment plan. But in the event that the consumer isn't quite ready to do that yet, they'll continue to just sort of talk to them through the door for a couple of visits, or say, okay, if you don't want to participate in this, there's something you need, and maybe there's just something that you can get, so you sort of chip away at those steps of engagement. And then most of the time they find that people will open up and be more involved. So they really do great work there. So.
And I have to agree with you. It seems like it's been a couple of years now, but early on, we had one of the case managers from that treatment team, and I cannot remember her name, but she did such a beautiful job talking about how, just having someone open the door a crack is a huge, can be a huge success. It's a big step. I think waiting for someone to take their medicine every day to celebrate success is misguided. You really got to start celebrating with the smallest of successes. And I love that you're working on that in the hospital. I love that. And I can't remember, were you in the training that we were at in it wasn't Louisville, it was
Lexington.
Lexington, yeah.
I wasn't in Lexington. Dr. Wilson, our director of psychology, was there.
Right. And the one thing she emphasized was starting that process, preparing for discharge, and the handoff to the provider, and how important that was. So those of you who are actually doing the work, do you have the opportunity for a warm handoff from the hospital? Because I know that many AOT programs are set up in areas where the hospital is so far away, it's impractical to go and do that in person. So I'm just curious. And Cassie, you're shaking your head. Is that your situation?
Yes, and we have 5 AOT clients, and each situation, our state hospital has communicated with us days ahead of time, before the discharge, and they've done a hospital transport to our crisis stabilization unit. So it's essentially a secure transport to our step down. Yeah.
And so they stay there for
just a couple of days, a day or two, to introduce ourselves, the AOT team, to them, and kind of meet with them outside of that state hospital environment and make sure we've got a good plan in place.
Yeah, I like that approach. Brings the person to you instead of discharge, and then the possibility of losing someone.
Yeah.
So go ahead.
Where do they go from the crisis stabilization unit? What are some of the diversion options that you have?
For our AOT clients,
yes,
some of them have went home with family. We've got, I think, 2 others that we transitioned directly to our ACT program, that had housing that they could pay for. And I think we've had one that has long had roots at a local homeless shelter, and we knew where we could find that person. But in terms of housing, River Valley, we don't have that. Either family, we get housing set up through ACT, or homeless shelter if we believe they can, plant some roots there.
Matthew, how do you get started with your new folks?
Starts with our treatment coordinator and coordinating with the case manager and our judge. We have a really good judge, Alan Zombrecker, 22nd JDC.
Mm-hmm.
I think Tara, I think you were mentioning about a judge. Judge will go to their house, sit outside. He sat outside somebody's window talking to them and trying to encourage them, you know, letting them know that, you know, hey, this is a collaborative effort.
What?
And I think because everyone in our program has some issues with law, with the legal system, and they're doing it not just because of concerns about med compliance, but they're looking at jail time. You know, so the legal, you know, we try to coordinate with the legal system, law enforcement, to really look at, hey, this is a severely mentally ill person, and they need to be on meds, they need various services, you know. So yeah, our judge is very committed. We have we collaborate with the 2 ACT teams in the area. So we have a few clients that are in there. We have 2 of our clinics. I'm in the Slidell Behavioral Health Clinic, and we have a clinic in Mandeville. So our clients are with the prescriber. They have a counselor. We also have at least 2 or 3 peer support specialists that will meet with our clients, call them. We have a NAMI worker specifically working with AOT. Also, our attorney. Our attorney is real good with talking with family, talking with the clients as well. Because sometimes clients will fall out of favor with different staff for whatever reason, you know, due to their mental illness. They may feel like someone's against them, so they'll talk to this one more. And so we just try to work. We don't want clients to feel intimidated at all or forced to do anything, and just really want them to be a part of their treatment process. You know, so yeah, I think if anything, what I'm learning here is just really gentle approach with clients to really make them feel comfortable about we're here for them, you know, and that's, I think, the thing that I'm hearing everybody else share.
This is a first.
Yeah. Yeah, I think I heard once a judge say that he took somebody for coffee, but never that they've gone to their house.
Sitting outside the window, sitting outside the window, talking through the window, and just, you know, just wanting to make them feel comfortable, and it may be at a request from a client. You say, look, here, what can I do to get you? Say, well, you can come to my house. So you say, well, what level of well, hey, can you sit outside the window? Sure, I'll sit outside the window, and we'll talk for a few minutes, and just let me know when you've had enough, and I'm good. You know, so and Judge Zonbreaker, he was good. It was not, you know, it wasn't an imposition on his part. He just felt like he was glad to for the client to okay, hey, we talked for 15 minutes, so that's a good sign.
That's awesome. Well, if that ever happens again, you got to take a picture.
I will do that. Have him take. Yeah.
I'm sorry. I have this vision of I always work from home, and I sit next to a window, and I have this vision of somebody peeking up. Hello.
Yeah.
But no, that's just amazing. Amazing.
Yeah.
I'm going to ask the question, but I know the answer. Anybody have any judges that do that? We have judges that write letters, but that's a first.
Yeah. So I'm gonna have to give Judge Zonbreaker some props then when we see him for next court.
Yes, tell him that we all applaud his efforts. That's amazing.
But that's not uncommon. We have heard, you know, like you say, some folks have just, you know, for whatever reason, have had bad experiences with the mental health system, and they're not open to receiving that positive message from them. But when it's a judge, you know, sometimes they can open doors that the mental health system simply can't, just because of past experiences. So that's awesome that your judge is willing to do that.
Yeah, but not coming at you like a judge, you know, like an authoritarian type, you know, just, hey, I'm just coming here as one of the members of the AOT team, and we're here to be of support to you.
Wow, that's amazing.
Yeah.
So Misty or Anne Marie, how do you get started with a new person?
You hear me?
Yep.
Yep.
Okay. So we work with the hospitals. We're getting in the process now where we're able to work with them directly. And a lot of them are helping us get them before they come out of the hospital. And then we also, I don't know what her title is. What's the one that we work with at the court that sends us those referrals? What's her title?
She just works with the DA office.
She works with the DA office, and she's also sending us referrals and stuff. And our judge hasn't had them at the house, but he is very, very open to them. Same thing. We just go in and chill out, and he's given some of them his personal cell phone number, which we highly advised against, but he did it anyway. And then he always tells them, we'll go for coffee, whatever, you guys can come in. He just keeps that open door policy for him. But that's mostly how we get started. We also use the clinic, and we watch for the emails that come across that person's getting out of the hospital or getting released from jail or whatever. And we'll try to catch them when they come in for that first appointment following that. And so that's the biggest part of what we're doing right now.
Anybody have any?
Anne Marie, I think Anne Marie was going to answer that question. Oh, maybe not.
And I'm trying to unmute you, and I cannot do it either. Oh, I can ask you.
Oh.
Can you hear me? Usually I'll get them when they come in for an out of hospital, and I'll sit down and talk with them and kind of explain that they can get more support in more ways if they come into the program. And that way we can answer questions one-on-one. I have a handout that we use, and we kind of go down that on what the different services are that they can access if they want them.
So what if they don't show up?
I've only had that happen once, but in my position, I can actually go out to their house and talk to them about it if I need to.
Because I would think that's surprising to me that has only happened once. That's pretty good. That's pretty good.
A lot of the ones that we find in crisis, that's what they're looking for. They're looking for more support and more one-on-one time and stuff like that.
Oh, that's great. Is that what you're finding, Tara?
No. But we designed our program as an ACT team. So we're not only serving people who qualify for ACT services at this point. A lot of times we're getting folks that voluntary ACT didn't work out for. So we're kind of ACT plus at this point. And so we're definitely seeing more of the folks that lack insight. We've gotten really creative. Like my team got an intake done in one visit this week, and that's never happened in 3 years of our program. So that was a win. So we get really creative about how to engage people in intake, and we really my staff's really good at like finding one thing that we can get some buy-in on. So like, you need to replace your ID, you really want that. Okay, that's something we can work on together. Or you want to get food stamps, or you like just whatever thing fits a service definition that we can work on that they're motivated by, then we make that like the main goal while we're working on building that rapport. And that's been pretty effective. It's usually not treatment. That's usually not the thing that we can engage people on, but we can usually get to like, if you can tolerate 30 minutes of us working on this paperwork, this is what allows us to then go help you get your ID. So that's usually pretty effective, but it's taken quite a few visits to get those intakes done most of the time.
I really like what you said earlier on how you let the prescriber, I think it was a psychiatrist, a doctor, they're dealing with the medication. You're not going in there starting your conversation with, you know, we expect you to take your medication every day, and that's what we're here to do, is help you take your medication. And oh, by the way, you have to take your medication. And I think that is a great way to start that conversation, start a conversation, because I can't tell you how many, as a supervisor, how many treatment plans I've reviewed where the main goal was to take my medication every day. And that's not anybody's goal. That's not my goal ever. So I really appreciate that. I'm just curious, does anybody, and I'm hoping Matt maybe have this, because he's got the judge who goes to people's house, but do any of your prescribers use shared decision making in their interactions? Do you, and I'm assuming you all know what that is. Do you? And I can't tell, Misty, if you seem to shake your head yes.
Yeah, I'm thinking I know what you're talking about. So our provider works with the hospital doctors while they're in the hospital, and they are coordinating the care through that. That's something that we've just recently been able to establish, though. And then she will give the report to the judge and the attorneys as needed as well. And if there's like APS or CPS involved, she also will work with them. And that way everybody's just on the same page, and we're all, you know, trying to help the person the best way we can as a team.
Yeah. So shared decision making is an intervention where the provider and the patient engage in a conversation about what is best for that person. So for example, the prescriber would outline benefits, risks and benefits of all the treatment options, and talk with the patient about what option seems to make the most sense for them, and be very attentive to concerns about side effects. And I'm just wondering, do any of your, Terry, do you have a psychiatrist that does that?
Oh, Amy, we have an amazing psychiatrist. He's been with our agency for years. He used to work at one of our clinics, and then wanted to do community work. So he splits his time with our team, our first episode psychosis team, and mood treatment center outside of our agency. But he makes house calls. He'll go on walks with people. He's really very person-centered, very focused on building rapport. We've had people who have, you know, been through the system a lot, come in with all their arguments prepared to advocate for themselves so that they're heard, and then they walk out and they're like, I didn't need any of that. He listened to me. So he's really popular with our clients who have not felt heard in the past. And he's, you know, as long as things are safe, he's willing to let people try things that might not be his clinical recommendation if, you know, if he were making that decision on his own, but it's not an unsafe thing to try. And then that opens the door to have a conversation of like, hey, we tried out that thing you wanted to try. It seems like maybe it didn't get where you wanted to get, like, and do we have that trust now that I can make a suggestion and maybe we can give that a try, like we gave your idea a try.
I just have to say, as the mother of a a grown adult son now with serious mental illness. When he turned 8, I never let him participate in those conversations with the psychiatrist. It was whatever he prescribes, you're going to take. And then when he turned 18, guess what? That was the end of that. And he hasn't taken any medication since. So I can't impress upon you how important that is.
And that's there's a real art to that conversation. And of all the psychiatrists I've ever worked with, I think 2 have been able to do that really well. And surprise, surprise, both of them were always behind on their schedule. They actually took the time to talk to their patients. What other kinds of creative ways do you work to engage?
I mean, well, we have some clients that are not taking medication at all. You know, they refuse to take any kind of medication, but you know, hey, we want to continue, you know, encouraging them, having a case manager go out there, having an NAMI support, having them, you know, talk to a counselor here, try to work with family. And, you know, we just try to keep, you know, like everybody else has said, you know, hey, what are some other needs that we can help you with? I see that you got in trouble with the legal system here. How can we help you get out, you know, avoid or reduce that? You know, it seems like if you're working with us here, that will help something there. You know, so I mean, we try to get creative with trying to help them engage in other areas. I mean, but we do have a few people that just refuse to take any kind of medication at all. You know, so I'm open to any suggestions that you guys have with that.
So Matthew, you've mentioned a couple times about your work with NAMI. I'm just curious, you know, what are you doing to engage families, or what's NAMI doing? What does that look like?
We have a NAMI worker that will go to the home as well. A NAMI worker that specifically works with AOT court, but also each clinic has about at least has 1 or 2 NAMI workers. So that AOT NAMI worker goes to the home, but also if, you know, the clients are coming to the clinic, you know, we have 1 or 2 peer support specialists, that will try to engage them a relationship, and they can do more community things with them. You know, we have, you know, hey, you got, you know, go to get coffee with somebody, or, you know, just do something, you know, go outside and smoke a cigarette with them. You know, hey, they don't want medication, but they're not, peer support will go outside, smoke a cigarette and talk to them. Hey, you're having some difficulties getting along with your mom. So how can we help that out there? Seems like, you know, so we just try to find other ways to get other staff involved, and just keep, you know, throwing small pebbles, you know, tilt the scales a little bit to try to get them more engaged. Some folks still don't want to take the medication, but you know, hey, we keep plugging away.
I love that, you know, you seem to have the flexibility. If something's not working, let's try the peer support, or let's try the NAMI person. Let's send this person in. And I think the patience that you show in not, or in staying engaged with them, even though they're not taking medication, is so important.
Yeah.
You know, we had a webinar, and again, a couple of years ago, about medication adherence, and the psychiatrist was a strong proponent of shared decision making, and he said, you know, if you're going to use this, you really have to be in it for the long haul, because it may not be 6 months. It may not be a year. It may be 3 years
Yeah.
before the person trusts you enough
Yeah.
to take the medication. So if
Yeah.
you can, if your support is able to keep the person safe while they are considering their options, I think, I mean, that is good work. That is good, strong work.
Amy, the hardest thing is just try to keeping the families engaged, because sometimes they think, you know, your role is to make our family member take the medication, you know, so, you know, we just kind of, hey, no, this is our process here. You know, we do need them to feel, you know, good about what we're trying to do, and we're supportive of them, not trying to, you know, enforce what you're wanting to do. You know, no, we want to help them the best way possible. So just really, you know, trying to get family on board with that. Some may feel frustrated with the process that, hey, this has been a year and I don't see any improvement here, but hey, look here, you know, he's letting the judge come sit by the window and talk, you know, you know, hey, he wasn't letting anybody come in the house, you know, come to the apartment. So we just, you know, trying to get the families to look at, you know, you don't realize the size of the step doesn't necessarily dictate the size of the outcome. Just the point that the judge is doing that, you know, at some point that client could, you know, could change their mind and say, okay, I'm willing to try something.
Yeah. Sounds like Betsy could have used your team when her son was 17.
Yeah.
And I know the point of the conversation is to discuss barriers necessarily, because those are pretty easy to find. But I think one of the real challenges here in terms of the long-term gain of building that trust that we're dealing with is just are the labor shortages and the employment movements that we have of staff. I'm sure most people are experiencing the same things our hospital and partner CMHCs are. There's not enough people, and people are moving frequently. So it creates a real challenge, and I don't know how to solve that, but I do know that it really hampers that ability to build those sorts of relationships.
Well, one thing I would just say, it seems to me, you know, that could be something that you've got to make sure that the judge is aware, you know, that the mental health system, I'm sure that most people are aware of that at this point, but, you know, judges don't turn over like others do. So that's why their role is so imperative, that they make that connection, because they may be the one constant, you know, in that person's life throughout the case. So I think that we need to just make sure judges are aware of how important that role is.
No, totally agree. And I know for a fact that Tara has struggled with that. So how do you all manage staff turnover? Not just how do you keep staff, but you know, when that happens, you've got a client who has a relationship with this person, and that person moves on.
Well, you know, ideally you can transition. That's of course the kind of care that we want, but sadly in these current conditions, a lot of times it's, you know, make do, and there's some gap in coverage. So that's not, you know, not what we want, but, you know, ideally there'd be some discussion and introduction and some time together to help transition that client so that they feel supported. I think, you know, the only thing to do is just acknowledge it, say, I know this is another change. And you know, you may be feeling this or that way about it. Happy to talk about that, but just want to acknowledge that another change is difficult when you're in the middle of already trying to do some work that is difficult in and of itself. So that's all that I can I mean, I'd love to hear more solutions, but that's kind of where we are.
So I'm not a clinician, so this may be totally inappropriate, but is it okay when you're interviewing folks for these positions? Is it okay to say that, you know, you're going to be working with a really vulnerable population, you know, so we want you to come in, you know, just being more, I don't know, selective in terms of who you pick for some of those key roles and making them aware that, you know, this is,
Yeah.
you know,
So
I don't know, if
you-
you
you
do
a-
that
you-
anyway, but.
You ask a very good question. I think there's a couple challenges. For 30 years, I've been trying to help people understand who they're going to be working with. Everybody nods and shakes their head and they think they understand. And you don't understand until it's looking at you in the face. And your question is entirely reasonable. And I think it's the challenge is how can we best help select the right people? It is just an uphill battle every single day. And it's always been like that, but it's just worse now. So I don't want us to get overly focused on barriers, but that's just a significant that we're facing, and it absolutely has a lot of impact on those relationships.
Excuse me, can you all hear me? This is Sheridan.
Yeah.
Good. I just want to throw out a few things very quickly. I've been a chaplain and spiritual counselor for many years. My Master of Arts is in theology, which is obviously the study of God. The thing with any of this, as far as I'm concerned, we need to look at these terms: recidivism, normalizing, empathy, bedside manner, and the other part of that is faith. The reason I'm bringing this up is because so many people who are experiencing mental health challenges, it's not just the mind. That's not all this is about. It's not. It is very important. We've talked about this already. I've listened to everybody. It's very important that we meet people where they are. And I don't mean on the phone. I don't mean on Zoom. I don't mean any of that. I mean in person. It's called outreach. And there are people who are saying we're doing outreach. Well, no, you're not. You're not doing it right. So that's what we need to talk about, because there's some steps to doing that. Absolutely. First is trust. If within the first minute or two, you do not develop trust with that patient, they're not listening to you. They've already made up their mind anyway before they come in. I'm not taking any medication. I don't want to be hospitalized. But the bottom line is, yeah, you do. We cannot continue to have patients come into the psych ward for 48 hours, or 72 hours and throw them back out there on the street. Because what do you think you're going to get? Well, what are we supposed to get out of that other than sickness? And what I call dis-ease, a dis-ease in the spirit. So that's what this is huge. It's huge because this is, when you're talking about faith, you're talking about culture, history, all kinds of stuff. So it is important. I mean, very, very, very important that we really, really, really not just add that component, but deliver on it. What I see happening that needs to happen, let me make myself clear. There should be mobile crisis units every other block in South Dallas. I'm just going to go there with you all today. Not in Highland Park. That's not what I'm talking about. I'm talking about the poor in spirit. I am included. I'm included. I mean, my first, I don't know what episode was at 13. Well, we got to understand that when a child's mind is developing, it takes a while. It takes men 25 years. Those are the statistics for the mind to be in the right place. So I have to go. I'm sorry, I have another appointment, but I did want to bring that out because just like I said, we're not talking about a disease. We're talking about a dis-ease in the spirit. They go together. It's all about the mind and the heart. Doctor, you know what I'm talking about. You know exactly what I'm saying. Because what it becomes is psychosomatic. And then we got to go to me, where I'm talking about psycho spirituality. So, anywho, I appreciate you all listening to me. I have thoroughly enjoyed this conversation, and I look forward to more.
That's
Take
great.
care.
Thank you for joining.
Absolutely. God bless. Bye-bye.
Bye. I think Sheridan brought up a really good point in terms of hiring, that it's not necessarily about the skill, but really thinking about temperament. And once you have someone hired, I know for myself that when I didn't go into social work planning to work with this population, not at all. I took this job. I took my first job as a case manager because they're the only ones that would hire me, because I didn't have a mental health related degree. But someone took a chance on me, and let me tell you, I mean, working with this population was so meaningful, the hardest job I've ever had definitely was a case manager, for sure. But the work with the people just really gave me the energy. And I think that as much as we'd love to increase everybody's pay and give everybody 4-day work weeks and all the benefits that we can imagine, I think without that real connection, I think it's hard. Now I'm sorry, I'm preaching to the choir here. Sorry about that.
That really speaks to me, Amy. I've gone through a couple iterations of my team in the past 3 years. And currently I have a team that really I kind of like went with my gut in hiring. Mostly folks who either fresh out of school or not a lot of experience, but that answered specific questions on the interview that were intended to elicit critical thinking skills and the ability to empathize and humanize people. And I've been able to build a team that is really adept at that and is doing this work because they're really passionate about it. And but also, we have a team understanding about self-care and work-life balance, and we really all practice that together. And I feel like that's why my team, this iteration, has lasted longer than any other, because we're committed to the work, but we're also committed to taking care of ourselves so we can do the work.
So important.
Quick comment, Amy, just what Ms. Sheridan was saying. I think, and Matt, what you were talking about, how do we retain staff? And I think for us, when we do give staff the opportunity, that's strictly working with our population who's severely mentally ill. And sometimes they don't necessarily get to see the big gains that somebody may see in a private practice, so they may be discouraged. So, so letting them kind of reframe that those gains are going to look different than somebody that you might see that isn't severely mentally ill, but also having staff working out other areas like prevention. Somebody's working with this population, hey, maybe doing something we're doing is we're trying to get a mobile crisis unit going on in our smaller rural areas where we don't have a lot of mental health services. So they're able to see firsthand, young folks that's, possibly their first episode psychotic, first episode psychosis, to really get them involved in treatment early, on the front end, and letting them, families see that, hey, that it's a support, it's not a stigma, it's a support that we can provide. And this is like if you had any kind of physical disease, you would want to go to a doctor, you would want to get the best health care necessary. And so trying to change that as far as the mental health system as well, that, hey, you want the best care and there's nothing shameful in it. So just being able to help staff be able to work prevention, as well as work with this population, I feel is helpful. Keeping staff from getting burnt out with it. And then from there, they kind of come in with a different set of eyes to work with the population. I mean, I've been here 20 years, so I mean, I'm here. They're gonna have to pry me out the chair. I'm gonna be, they might find me in the office, and that's gonna be it. But I'm here for the duration. So
Sounds like Matt is as well.
yes, yeah. 30. You said 30 years. I'm mad. I only got 20 with this year, but.
Well, I've had a couple of different populations, but this all resonates with me a lot. And I think that, from a hospital perspective, we see it's my job to help people see the longer term improvements, the wins that people who are working inside the hospital don't see once people leave the hospital. So I also think there's opportunity for people who work in the community on these are shared teams. So I'm not talking about sharing information that shouldn't be shared, but I understand you're struggling with this person at this point. However, just a few short months ago, they were here. And so that perspective, I think, is hard to continue to help people have. They don't have it on their own. They don't have it naturally. So you have to find ways to support that. Then the other thing is to had a leader that would talk a lot about part to play. Everybody has a part to play. So sort of, defining what that was and how it helped the overall large good, and how what the outcomes that were occurring couldn't without people playing that essential role. So, and as we've begun to have more evaluation and research into what's happening in Kentucky, we're having those success stories. And so in our last statewide meeting, we talked about, what are those opportunities to put together some things to educate probably some different audiences, family members, potential consumers, as well as just folks in the community. So, there are good stories there. So we need to start putting those together.
And
we often,
sorry,
no, you're right. Absolutely. The legislature needs to hear them too. But also we think it's important that you share those stories with some of the original referral sources so they know, because they may not see this person again. They may never know what happened to them. So you need to let them know what's going on with those individuals so that they're more inclined to look for those, candidates and make those referrals. But absolutely.
Did the teams do that, Matt? Matt is the referral source. Do you get to hear about the progress that your folks?
We do, but it just it's more anecdotal. And so, we can bring those stories back and share, and those are certainly impactful. But I think we have some data to use now, and that tells a different kind of story and can be put together in a product that just has a different aim and maybe a wider audience. So I think that'll be helpful. And I'm also a big fan of having different versions of things for who you're talking to, because there are different things to stress, so that people understand from their perspective the gains.
Well, everyone, there goes another hour. Thank you so much for sharing your experiences and your stories. I don't know about anybody else, but I know I've learned a lot, and I will forever picture Judge Zonbrecker in the window.
sitting on a stoop, huh?
In the window. thank you for joining us, and I look forward to seeing you around. Also,
Yeah, well,
just real quick, our next symposium, save the date, next November 2024. We hope to see you in Annapolis. So take care and have a great rest of your week.